Good morning. My name is Colin Fuller, and Dr. Carol Scott has asked me to talk today about protecting the heart of the American athlete. And it's my pleasure to do so. I've been in practice in Reno, Nevada for almost 40 years. I work with Northern Nevada Medical Center on the clinical faculty of the medical school. It's my privilege to talk to all of you this morning. I'm the sports cardiologist for the sports teams up at UNR, plus for the Reno Bighorns basketball team, and we're evaluating them right now for their safety of participating in sports. The benefits of exercise are numerous: improved self-esteem, pleasure, endorphins, camaraderie, recognitions, scholarships, income, weight loss, stress management, better sleep, better sex, decreased cardiovascular risk. But there's some non-cardiovascular risk factors of exercise: injury, trauma, lightning, drowning, heat stroke, sickle cell crisis, and other. The main cardiac risk of exercise is sudden cardiac arrest. These are the faces of sudden cardiac arrest internationally in elite athletes every year happening. In American professional athletes happening. In our local athletes, unfortunately. Sudden cardiac arrest is a rare event. However, it has a huge impact on communities. We're going to talk in part about how to predict it, how to prevent it. We're going to talk about a structured approach rather than an emotional, reactive one. I'm going to define an athlete as any individual who engages in routine, vigorous physical exercise in the setting of competition, recreation, or occupation. An occupation includes policemen and firemen. We'll talk about briefly the causes of sudden cardiac arrest, sudden cardiac death. Prevalence, we'll talk about the prevalence of conditions placing the athlete at risk for sudden cardiac death. We'll talk about the incidence of sudden cardiac death in young athletes. We'll talk about screening of young athletes for risk of sudden cardiac death. We'll talk about the limitations and the challenges. And importantly, this morning, we'll talk about the new international criteria for interpreting athletes' ECGs. And we'll finish with screening older athletes for risk of sudden cardiac arrest, sudden cardiac death. My interest in this subject began in 1991, a long time ago. A Douglas County athlete, a star basketball player, was in a game at Lawler Event Center. He collapsed and died. At autopsy, was found to have hypertrophic cardiomyopathy. His primary care doctor from Gardnerville, an excellent physician, he called me on the phone and said that he had performed the state of Nevada mandated pre-participation history and physical on this young man. And he was very, very disappointed. You know, how come I wasn't able to pick this up? And he asked a very key question: should I have done an EKG? Well, my response was, I have no idea. I knew nothing on the topic. I never had a lecture on it. I'd never read anything on this topic about athletes and why they die and how do you prevent it and how do you screen for it. And I told the primary care doc that I would look into it. I spent some time looking into it and found there were these causes of sudden cardiac death in young athlete in order of frequency. Hypertrophic cardiomyopathy being number one, anomalous coronary artery, ruptured aorta, myocarditis, aortic stenosis, dilated cardiomyopathy, right ventricular dysplasia, and the primary conduction abnormalities. And just briefly, just for a nice overview for you, I'll mention a little bit about each one. Hypertrophic cardiomyopathy, as many of you know, is generally an inherited condition, autosomal dominant, incomplete penetrance. It's frequent. About 1 in 500 adults have hypertrophic cardiomyopathy. It's hypertrophy of the left ventricle. It doesn't have to be asymmetric. It results in fiber disarray, putting the person at risk of ventricular fibrillation. And almost always the ECG is very abnormal. Anomalous coronary artery. Here, as shown on the far left, you have the normal situation where the left main takes off from the left coronary sinus, shown here. See if I can make a dot, and takes a normal course. And then the right coronary taking off from the right coronary sinus. But in the anomalous coronary artery situation, the more at-risk situation is shown here, where the origin of the left main is adjacent to the origin of the right coronary artery. And when it takes off, it's a right ankle. It's a slit-like orifice, and then it courses between the aorta and the pulmonary artery. And you can imagine during exercise, when those great vessels become dilated, it can compress the left main, putting the person, the young child, at risk for ischemia and fibrillation. And then you can see, not as common, as shown on the right, where the right main starts adjacent to the left main with the same potential consequence. Cystic meninocrosis of the aorta is the problem with Marfan syndrome. Marfan syndrome, again, a congenital abnormality, as shown here in the Netter diagram on the left of this woman. Very long arms. These people are often volleyball players, basketball players. They have ocular abnormalities, they have skeletal abnormalities, and cardiovascular abnormalities. But the cardiovascular abnormality that kills them is cystic meninocrosis of the wall of the aorta, as shown here in this pathology slide. Flo Hyman, in 1984, was an Olympic silver medalist. She had Marfan syndrome. 2 years later, she suddenly died after leaving a game in Japan from a ruptured aorta. Myocarditis, as shown here, typically has an abnormal ECG. Congenital aortic valve stenosis, abnormal ECG. Dilated, moderately hypertrophied heart, abnormal ECG. Arrhythmogenic right ventricular dysplasia, abnormal ECG. These are the kids. There's about a prevalence about 1 in 2,000 people have this condition, where the RV initially is replaced with adipose or fibrous tissue, males more than females, familial predisposition, exam is normal, and their ECG is abnormal with T-wave inversion V1 through V4, and their echo often has the dilated RV, but what really makes the diagnosis, if you suspect it, is cardiac MRI. Primary conduction abnormalities, long QT syndrome, the prevalence about 1 in 2,000. WPW syndrome, 1 in 1,000 prevalence. Brugada syndrome, 1 out of 3,000 individuals have this. The ECGs are abnormal 99% of the time. So when I finished my research back in 1991, ages ago, I realized, as shown here, that 6 of these 8 conditions, putting young athletes at risk for sudden cardiac death in the playing fields, typically have an abnormal ECG. So I convinced my partners in our cardiology group then, back in the early 90s, at Sierra Nevada Cardiology Associates, to screen all young athletes in Northern Nevada as part of their usual screening for playing sports. And so fall, winter, spring, we went around to all the schools, we donated our time and effort, and ended up with 5,600 young athletes that we did the Nevada mandated cardiac history and physical, to which we added a 12-lead ECG. And if any were abnormal, they received an echocardiogram or other cardiac testing. What we found, I'll try and make this slide simple for you, up here, the sensitivity of the history and physical, the American Heart Association specific cardiovascular history and physical, sensitivity of picking up these conditions we just talked about is 6%, whereas the 12-lead ECG, you pick up 70% of the abnormalities. Now let's look at specificity. For the history and physical, for picking up these abnormalities in young high school athletes here in Northern Nevada, of all the kids who did not have disease, almost 98% of the time, their history was negative. About 2.2% of the time, a kid would complain of something and we didn't find anything wrong. So specificity is high. The number of false abnormalities was low. But unfortunately, and this is the drawback to the ECG, specificity was relatively low. That's 15.7% of athletes. 1 out of 7 athletes would have an abnormal ECG but had no underlying abnormality. The next year, the American Heart Association responded to our publication that I mentioned a second ago. And I should add, I'm going back to the prior slide shown down here, this in red circled, that $44,000 figure. That represents the cost effectiveness of using an ECG to screen a young athlete for risk of sudden cardiac death. It was $44,000 per year of life saved, not far from the cost of doing dialysis to keep someone alive. But for the history and physical, mostly because of the low sensitivity of the test, it was much more expensive. So despite that publication and making that statement, and we at that time were the first publication in the world literature to even bring up the topic of better screening. We suggested an ECG was better screening. The response to the American Heart Association back in '96 and a year later, a white paper published in Circulation, was, here's your problem, guys. That 15.7% of athletes whose ECG is abnormal, but they don't have anything wrong. And that's because I had nothing to go on. I devised what I'll call the Nevada criteria, and I wanted to be liberal. I don't want to miss any kids. And so I went to the adult criteria or maybe the pediatric criteria to choose criteria to call an ECG abnormal. And I agreed with them. It was too many. And I went back to being a clinician, and they made their recommendation. They said both a cardiac history and physical examination should be performed before participating in organized high school, grades 9 through 12, and collegiate sports. Screening should be repeated every 2 years. They said ECG should not be used. And their evidence for recommending the history and physical, 0. But you know, the history and physical is almost iconic. We've been taught that for centuries. No, not centuries. Certainly since the 40s here in America, that's the way we evaluate someone initially. And they didn't want to deviate from that. And as I mentioned, I went back to being a clinical cardiologist in Reno, Nevada, but fortunately others pursued this. It kind of started, it raised questions. And now I'm going to take you up to 2016, where the American Medical Society of Sports Medicine published a position statement on cardiovascular pre-participation screening in athletes. It gave current evidence, knowledge gaps, recommendations, and future directions. In those 20 years, from '96 to 2016, there are thousands of papers now that have been published. It's become a hot topic for the NCAA. Lots of issues. So let me share with you what we know today in 2016, 2017. Who is at risk? What kids have that problem? So the prevalence of this condition is 1 in 250. 1 in 250 young athletes have a previously undetected cardiac condition, placing them at risk of sudden cardiac arrest, sudden cardiac death during sports. What's the risk? What's the incidence when you play sports? In high school, as shown up here, it's about 1 in 50,000. NCAA athletes, about 1 in 40,000. NCAA male Division I basketball players, 1 in 3,000. And if they're an African American male NCAA Division I basketball player, 1 in 1,000. Very high risk group. Marathoners, somewhere between 1 in 50,000 and 1 in 100,000. Importantly, they embraced what are called now the international criteria for ECG interpretation. I started out with the Nevada criteria. We have evolved now to the international criteria, which I'll talk about a little bit with you shortly. And what they were able to do is say they're green criteria, they're yellow, and they're red. The red right here are the red flag. That is about 20% of what were the original Nevada criteria. The rest of the Nevada criteria, the borderline ECG changes, these the yellow and green, are normal changes to the ECG in athletes and don't need further evaluation. And indeed, what helped develop the international criteria was data that we presented. Dr. Scott and I, Dr. Pasternak, Dr. Cheryl Hug English, we got together back in 2008, and it was really Carol's brainchild. She said, Colin, let's start screening up here at the university with our athletes and see if we can't do a better job of screening. So we indeed, over quite a few years, were able to generate data on 1,500 athletes. And if you remember, I mentioned a little bit earlier, the prevalence of disease is 1 in 250. So those 1,500 athletes, how many would you expect us to find would have disease, putting them at risk for sudden cardiac death? And the answer would be, if there's 1,500, 1 out of 250, about 6. And that's how many we found, 6. After cardiac testing had disease. We had 3 with hypertrophic cardiomyopathy, 2 with WPW, both Parkinson-White syndrome, and 1 with a dilated cardiomyopathy. And as pointed out, we were able to look back at all of our ECGs, 1,500 ECGs, and now, using the strict international criteria, the false positive rate, the number of abnormal ECGs, we'll call it, was only 2.83%, much lower than the 15.7 we started with back in the early 1990s. So this has become a practical approach to screening athletes. So let's talk about the international recommendations for electrocardiographic interpretation in athletes. Indeed, these have been published. As you can see down below here, if you refer to that website, you can get the criteria. And my purpose of my talk today is not to make you electrocardiographers, someone who can interpret EKGs, but to give you a foundation of understanding where we are today. You will have kids who will come to you, athletes, and they'll have a symptom. The coach wants them to be evaluated by you. Their parents do. Maybe the kid does. And you'll, as part of your evaluation, get an ECG. I want you to be aware we now have specific criteria to interpret it. Unfortunately, if you look at the computer interpretation, it'll over-interpret it, call many abnormal that are not abnormal. If you give it to an adult cardiologist, unfortunately, they don't know how to interpret athletes' ECGs yet. That's why I'm giving this talk to you, and I'll be giving it at Renown in December at Grand Rounds, and why others like myself who are interested in this topic are talking about it across the nation. Why it's published recently is we're trying to expand the knowledge so that you, the primary care docs, be given the right interpretation of an ECG so we don't over-test a young athlete. And so there are many societies that have signed on to this throughout the world. This is published in the official Journal of the American College of Cardiology. I've signed on to it. I believe in it. I think it makes a lot of sense. But let me explain why it makes sense. You have to ask the question, if you're going to have more strict criteria, do you reduce the sensitivity? In other words, more strict criteria, are you going to miss kids? Of all the kids that have disease, with strict criteria, you're going to miss a certain number. And the answer is, again, going back to all these studies, again, we have specificity now. Number of false positives, pretty low, between 3 and 6% is shown by our group over here, and many other groups over the past few years. And indeed, we've gone back, and the reality is almost no change in sensitivity. Almost 100% sensitivity for sudden cardiac death associated conditions. All 3 criteria identify 98% of athletes with established hypertrophic cardiomyopathy. Almost 100% sensitivity for the pathological condition detected. So we feel we're not losing sensitivity while we improve specificity. So I think what this slide kind of tells where we are today in 2017. When we started back here with the Nevada criteria, it was kind of like, Neanderthal man. Now we're with, these star athletes. We've made progress. We've evolved. We have much better way to screen young athletes. So here's a fair question. Why does the ECG change? Why are there changes such as a lot of LVH and incomplete right bundle branch block? Why do you see axis deviation, atrial enlargement, etc.? Well, and the answer is, it's the athlete's heart. The athlete's heart develops changes electrically and structure-wise, due to training, and if they detrain, the ECG changes and the chamber changes, chamber enlargement, the chamber hypertrophy can go away. And so as a result of sports, and it depends a little bit on the type of sport, you know, the football players can have different changes on the heart than the rower, than the basketball player. It depends on the age of the athlete, the gender, the size of the athlete, and the race and the genetics involved. And you're going to see enlarged chamber sizes, as shown up here. You're going to see increased wall thickness, cavity dimensions increase. It's all physiologic. As a result, you can see voltage criteria for LVH, voltage criteria for RVH, incomplete right bundle branch block, etc. Also, because of training, you have increased vagal tone. We all know the athletes have slower heart rates. You can have heart rates into the 30s, acceptable, typically at night. Sinus arrhythmia, early repolarization, first degree AV block, Mobitz type 1, second degree AV block, that's where the PR interval prolongs, and then you drop a QRS complex. That is normal and physiologic. So let's go back through those green findings that I originally thought in the Nevada criteria, because I didn't have any reason to think differently, were potentially pathological. They're not. So left ventricular hypertrophy, shown here. Here we have an ECG from a 19-year-old asymptomatic soccer player demonstrating voltage criteria for left ventricular hypertrophy. Lots of voltage in this. Big S wave here, big R waves laterally in the precordial leads. We see these on ECGs. When you see it in a young athlete, it is normal. Doesn't require further testing. It's seen in the majority of athletes. Voltage criteria for RVH. It's seen in up to 13% of athletes. It correlates poorly with RV wall thickness on echocardiography. Isolated voltage for RVH does not correlate with underlying pathology in athletes, particular arrhythmogenic right ventricular cardiomyopathy or pulmonary hypertension. How about incomplete right bundle branch block as shown here? That's your V1, the rabbit ears, without prolonged QRS complex. This mildly delayed RV conduction in athletes is caused by RV remodeling. Think about what the athlete, they're training, increased cardiac output, stretching of the chambers. There's remodeling that's positive. Increased cavity size, increased cavity, you can have increased cardiac output. No evidence of intrinsic delays within the His-Purkinje system. It represents a phenotype of cardiac adaptation. It is as normal, doesn't require additional testing. Early repolarization. These ECGs where you have this ST segment elevation here, you have the anterior precordial leads, V3 and V4 and V5 and V6, and even inferiorly, all those blue arrows. That finding of ST elevation in an athlete is normal, does not require additional testing. How about repolarization specifically in black athletes? 2/3 of black athletes exhibit ST elevation and 25% demonstrate T-wave inversion. Let me give an example of it. This is an ECG of a 24-year-old asymptomatic black African soccer player demonstrating, as you can see here in V2, V3, and V4, J-point elevation. It's convex, upward sloping, ST elevation followed by T-wave inversion. If this young athlete walks into an ER with chest pain, they're sending him to the cath lab. I'm telling you right now, and the athlete doesn't have chest pain, is in front of you just for, let's say he's, family want you to be thorough, want you to get an EKG before they play sports. This is normal and physiologic in a young black athlete, does not require additional testing. How about the juvenile ECG pattern? You all see that if you get an ECG in a young person who's not yet had puberty. You will see the T-wave inversion or biphasic T-waves that can go beyond V2. In those who are beyond puberty, T-wave inversion beyond V2 can be pathological. That requires additional testing. But if they've not achieved puberty, T-wave inversion in V1 to V3 should not prompt further evaluation. We're trying to make sure unnecessary testing is not occurring in our young athletes. So here we have a young athlete. Now here, there's no, as shown here in V2 and V3, there's no real significant ST elevation like you saw in the black athlete who had T-wave inversion, but then you have T-wave inversion out to V3. In someone who has not had puberty, normal doesn't require additional testing. Bradycardia, very common due to increased vagal tone and possibly structural atrial remodeling. In the absence of symptoms such as fatigue, dizziness, or syncope, and with a heart rate greater than 30, no further testing is required. Some other common findings in athletes. Due to high vagal tone and intrinsic AV node changes, you can see sinus arrhythmia, junctional escape rhythm, ectopic atrial rhythm or wandering atrial pacemaker, first-degree AV block, present 7.5% of athletes. Mobitz type 1 block, we talked about that. If you put any of these kids on a treadmill, all of those findings will go away. Now, how about the borderline ECG findings? We just discussed the green findings, normal and physiologic, don't require additional testing. And again, you may be getting an ECG on an athlete because the athlete comes in with a complaint or the parents or someone wants you to do screening. We're going to now move on to borderline ECG change. The left axis, left atrial enlargement, right axis deviation, right atrial enlargement, complete right bundle branch block. Here's the data. They, in isolation, don't require additional testing. There's a large study of 2,500 athletes versus almost 10,000 controlled, and they looked at isolated, either right axis deviation, left axis deviation, or right atrial enlargement, left atrial enlargement, present at 5.5% of athletes. I'll just share with you. Though they may have a little bit of larger left atrium, larger ventricular dimensions, no pathology was found. So these in isolation now. I'll go back. Oops, I pushed the wrong slide there. I'm going to go back one. Oops, right here. These here in isolation. Now, if you have more than one, they require additional testing, 2 or more of these yellow findings. But in isolation, not a problem. This will catch a little by surprise. Right bundle branch block in a young athlete, if found in isolation, does not require additional testing. It's present in 1% of the adult population and probably 1 or 2% of athletes. It often has to do with exercise-induced cardiac remodeling of the right ventricle. Again, volume overload doesn't require additional testing. And here we have right bundle branch block. You look at V1, you see the RSR prime, the rabbit ears. QR, by definition, means a QRS duration of 120 milliseconds or more. This is a 19-year-old male athlete, commented here, with complete right bundle branch block. In isolation, doesn't require additional testing. Now, this is different. This is right bundle branch block here. Okay? RSR prime is more than 120 milliseconds. But this is left axis, where the QRS is a negative in lead 2. And this is a little bit technical, but I'll share with you real quickly. The P wave there is higher than normal, where it's over 2.5 millimeters in the inferior leads. That means right atrial abnormality. Right there. Oops, right there, where the hand is. So that, when you have a combination, in this case 3, right bundle branch block, left axis deviation, right atrial enlargement, that athlete does need additional testing. So now let's move on to the red flag abnormalities. I'm not going to go into too much detail. I'm just going to read through these pretty quickly. I'm going to have to put my glasses on to do that because I'm that age. We have T-wave abnormality. If you have T-waves, so it means the definition, and I'll share with you. I'm just trying to give you kind of a background because this is new stuff. You'll hear more about it. You'll go to courses. You talk about young kids, EKGs. So like pediatric ECGs have strict criteria. Now when we look at adults, there's a separate group, the young athlete ECG. It needs different criteria. I just want you to be familiar. I know none of you, or most of you probably don't read ECGs, but just be familiar with what we as adult cardiologists are now being asked to do. And let me share with you, the time has not come to do this in high school athletes on a large scale for two reasons. We don't have adult cardiologists yet around the nation available to read these ECGs. We're trying to increase the number who know how to read them. And we don't have the proper knowledge as what test to do when a ECG is abnormal. We don't have a wide dispersion of that knowledge. We're trying to disperse that knowledge now. But just to briefly familiarize you guys with this concept, T-wave inversion greater than millimeter in depth in 2 or more continuous leads, excluding AVR3 and AVF, that needs further evaluation. Pathological Q waves shown here, that means the Q wave is more than 1/4 the size of the R wave, or it's 40 milliseconds in duration in 2 or more leads. Complete left bundle branch block needs further evaluation. Profound nonspecific IVCD requires evaluation. Now, there's QRS duration over 140 milliseconds. An epsilon wave, which is a distinct low amplitude signal between the end of the QRS complex known as the T wave, specific for RV cardiomyopathy, needs evaluation. Ventricular pre-excitation, that's the WPW syndrome, needs further evaluation. Prolonged QT is something to keep in mind. The corrected QT interval, QTC we call it, in a male, if it's over 470, needs further evaluation. In a female, 480. And certainly over 500, big red flag. Brugada type 1 pattern, specific pattern, profound sinus bradycardia below 30 or pauses over 3 seconds in a young athlete, not good. Profound first degree AV block over 400 the PR interval over 400 milliseconds. Mobitz type 2, this is where you have the PR interval is not increasing and you suddenly drop a QRS complex. Pathological, 3rd degree AV block, complete heart block. And then SVT, atrial fib, atrial flutter. And what you may see in your practice, you do a 10-second tracing ECG on an athlete, you see 2 PVCs and then 10-second tracing needs further evaluation. Ventricular arrhythmias, couplets, triplets, and non-sustained VT certainly needs further evaluation. So let me summarize then where we are in 2017. And this is from the paper I referenced earlier from the American Medical Society of Sports Medicine. There is limited evidence supporting the effectiveness of pre-participation screening to achieve the generally agreed upon primary objective, the prevention of sports-related death in athletes. The historical questions designed to detect previously undiagnosed cardiovascular conditions were developed through expert consensus and have never been validated scientifically. The addition of a resting 12-lead ECG to screening protocols has also never been shown in adequately designed study to prevent sudden cardiac death in athletes. But data suggests that screening by history and physical examination alone has a low sensitivity to detect conditions associated with sudden cardiac death. And the addition of an ECG, when properly interpreted, it's a key point, when properly interpreted, that's what we're trying to do, is to widen the number of people understand how to interpret these ECGs, and with skilled cardiology resources available, improves cardiovascular screening if the measurable endpoint is considered the detection of silent or congenital cardiac conditions associated with sudden cardiac death. So at the bottom, a good way to look at all of this, I think today there's a consensus that the history and physical is shown here. Its sensitivity for detecting these conditions is low. The false positive rate, I mean, how many kids that don't have disease will tell you they have something going on, about 10%. The ECG sensitivity, 7 out of kids who have disease you'll pick up, and the number of kids that don't have disease that will have an abnormal ECG, about 3%. I would, word of caution, though we're aware of what we do in Nevada, the state mandated history and physical has to be used by all of us to screen kids before they play sports and realize the kids aren't telling us much. And the reason they're not telling us things is because they ignore their symptoms. They want to play sports. That's understandable. But the reality is 50% of athletes with sudden cardiac arrest, death during sports have prior cardiovascular symptoms. So we need to pay attention to chest pain, shortness of breath, or fainting in a young athlete when you see him in your office. Now I'm going to finish the last 5 or 10 minutes here on the older athlete. This is a dinosaur running the Boston Marathon a couple years ago.
Great.
There are certainly cardiovascular benefits of exercise for the older athlete. That is isotonic, not lifting weights, but walking, running, biking, swimming. Decreased weight, decreased blood sugar, decreased blood pressure, lowered LDL cholesterol, reduced risk of heart attack, reduced mortality. I'm defining the older athlete as one over the age of 35, and in this case, think of coronary disease. Let me give you a little history. There's a 55-year-old male long-term endurance athlete. This is a patient I took care of recently without known medical history, presenting with reduced exercise capacity. He's active with daily endurance runs since his 30s, most recently completing 2 marathons per year at a very fast pace. He first noted shortness of breath, generalized exertional fatigue, and slowing in his typical pace about 6 months prior to evaluation. At angiography, as shown right there, he had a tight proximal 99% LAD lesion. We stented him. He's back to sports. And as we all know, these coronary arteries, the first branches off the aorta, are small, about 3 millimeters in diameter. But if you do a cross-section of a coronary artery and enlarge it, this is what it looks like right here in all of us when we were born, clean. But starting in our 20s, plaque develops. Plaque development in Americans is epidemic. If you take your age and put a % sign beside it, that's the likelihood you have plaque in your arteries. It may not be your coronaries, it could be your carotid, abdominal aorta, your leg arteries. So by the time you're a 50-year-old male, there's a 50% chance you have plaque. Most of the plaque is minimal or mild, but about 10% of those athletes in their 50s or adults in their 50s that have plaque, about 10% it's obstructive, and many times they don't know it. So let me share with you a few comments I heard made by these fit, middle-aged endurance athletes. And comments in line while I was waiting in a line for a porta potty before a 10K race. The first one, man, I'm not sure that second chili dog and extra couple beers last night was a good idea. Oh well, they always say don't change your routine before races. I wish my old man could see me now. He died at age 45 of a massive heart attack. Cough, cough, hack, hack. If this race weren't once a year, I could be home in bed. I feel like crap. Oh well, this race will help me clean out the junk. I'm glad I stopped smoking a few years ago. These are the older athletes that want to go do these races. Who knows why? So what's our responsibility? Well, we want to help them control the causes of that plaque. It's epidemic. Control their blood sugar. These are the modifiable causes of plaque. Elevated blood sugar, blood pressure, LDL cholesterol, and smoking. We want the person to maintain and achieve ideal body weight. No cocaine or methamphetamine, and I would recommend avoidance of performance supplements purchased at the gym. Who knows what's in them? I can tell you some very sad stories of young kids who've taken a lot and ended up with bad cardiomyopathies. Why should the middle-aged person consider exercise? This we're going to call our baseline. This is the couch potato. This is a relative relationship of risk of MI, and we're going to say it's 107. If you just get up off the couch and you start a couple times a week going out and walking or running or bike riding, you reduce that risk of a heart attack in the next years by 80%. And if you exercise more, it goes down even further. So exercise prevents heart attacks. But we just want to be careful before we have someone exercise that they're not going to have an MI with exercise. So we need to evaluate them. And I have 3 slides here, and I'll give you, this is my opinion. I think you should assess the health needs by asking these questions. Have you had a heart attack, heart surgery, heart catheterization, coronary angioplasty, pacemaker? Do you have valve disease, heart failure, heart transplantation? Do you have congenital heart disease? If the answer is positive to any of these, there's a need to see a cardiologist before starting, resuming, or increasing exercise. Symptoms. Do you experience chest discomfort with exertion? Do you experience unreasonable breathlessness or dizziness, fainting, blackouts? Or do you take heart medicines? There's a need, if so, there's a need to see a cardiologist before starting, resuming, increasing exercise. Cardiovascular risk factors. You're a man or woman over the age of 45. I think I'd almost say you're an American. You're a woman older than 55, or you've had a hysterectomy or you're postmenopausal. You smoke. Your blood pressure is elevated. You don't know your blood pressure. Your blood cholesterol is over 240. You don't know your cholesterol level. You have a close blood relative who's had a heart attack before age 55, father or brother, or age 65, mother or sister. You're a diabetic or take meds to control your blood sugar. You're physically inactive. You're more than 20 pounds overweight. If you check any of those, you need to see a cardiologist before starting, resuming exercise, or at a minimum, you need a treadmill test. If you can do a treadmill test locally, great. If not, have them see a cardiologist. And you know, I view this as it's an opportunity when you see these people who want to exercise to help them understand the reality is you got plaque. Exercise can be fine. Let's make sure it's safe before we do it, but then help them work toward preventing more plaque. Whatever their LDL is, help them bring it down. Bring down their blood sugar. Bring down their blood pressure. And we'll reduce heart attacks and death. So I'm going to conclude here and say I tried to give a foundation of where we are today in 2017 regarding the American athlete. The younger American athlete could be a runner, could be the older athlete. It could be a bike rider. In any of these cases, the things that we can do to screen them, or if they have symptoms, evaluate them, and certainly in the older athlete, the things that we need to do before they exercise to fully evaluate them. And hopefully these comments are helpful, are of help to you. And I'll finish there.
Do we have any questions for Dr. Fuller?
Thank you all very much.
Thank you. For more cardiology-related echo information, we've just started our cardiology clinic, which will meet next on November 9th. Hope to see you there. Thanks, everyone.
Thanks, everyone.